Okay, this is Pathogenesis Part 2, and this is just a very brief section, but what I wanted to talk about is different activity theories. So we've talked about periodontitis breakdown, the cellular pathway that happens in each stage, and then once a patient has apical migration of the junctional epithelium and bone loss, how does one then have periods of activity? Is it constant? And is it stop and go? And to be honest, no one really has a great knowledge of it, and every couple of years there's a new theory. So I wouldn't call this rock solid evidence because I feel like every few years there's a different theory. But right now, and there's different names of this as well, but basically the idea or the current view is that there's an intermittent progression theory, and that's that patients will have periods of activity and inactivity. So they'll be breaking down bone and attachment and then stop, basically, so that the tissue destruction, it's sporadic. Now the progression could last for a month, could last longer. Destruction does not occur in all parts of the mouth at the same time, and different areas can be active and other areas are inactive, which makes it very difficult to assess patients, really. So basically, and it's also that untreated gingivitis does not necessarily progress to periodontitis. In certainly most patients, that is the case, but there are a rare subset of patients that doesn't seem to happen. There are different forms of periodontitis that also seem to progress at different rates as well. So therefore, it makes it even more difficult to assess. So susceptibility to periodontitis varies greatly from individuals, and the presence of disease appears to be determined by the host response to the periodontal pathogens and not just due to the periodontal pathogens. For example, one patient may have high proportions of microorganisms but not be susceptible and not break down. So the fact that the host and how it interacts with the bacteria is also important. So that theory is called the host bacterial interaction theory. So activity, we're not 100% sure. That's the current thought. And then there's some research on rate of disease. So in 2017, Needleman reported that the annual rate is 0.1 for attachment loss, and that smokers tend to lose bone twice as fast as non-smokers do. So now patients may have active and inactive sites, like I mentioned, and then now how do you know and how do you determine this? And what's the difference between someone who is in an inactive state of perio? Well, the easiest answer is, as far as activity, we're not 100% sure. There are advanced testing to try and figure out if a patient is currently breaking down in an inactive phase, but that technology is either too expensive or not really reliable just yet. So we're off to be using older clinical parameters, and they're not great, but they're what we currently use for the standard of care of trying to predict whether your patient is active or not. So bleeding is a sign of active disease. Now, 50% of the time they have found that bleeding sites, when they follow them up, they don't break down, so they don't actively lose bone after. And 50% of the time, bleeding sites, they will break down. So what that means is we're not sure. And it also means that if a patient isn't bleeding, we know that they won't break down. So that's So the absence of bleeding is a great predictor. So we say when we see bleeding sites, we say that that's active perio, and we're mindful that we're going to be wrong sometimes when we make that educated guess. Another parameter we use is inflammation. So we know what's going on at a cellular level when there's redness, when there's inflammation. So when we see redness and swelling, we say it's the patient is active. So some other less common signs are the look of the bone. When you take radiographs at that time point only, it's thought if you see a prominent crest of bone in between the teeth as opposed to irregular or a rough surface, it's thought that it can indicate static or slow destruction. So a rougher, irregular look to the crest of bone is thought to be an active case. And I'll show you what I mean here. So in this slide right here, you can see how this is well demarcated, this nice radio opaque, clear interdental bone. This is beautiful, right? So not only does it look nice, there's also no bone loss. It's right 2 millimeters apical to the CEJ where it should be. So this is a sign of stable bone. Whereas in this bone right here, see how this is fuzzy? And not only that, but I see one bone is angled and one height of bone here on the buccal bone looks straight. So it looks like this lingual bone is in an active phase of disease. It's rougher looking. So looking at the radiographs that day can help you guess at activity. It's also thought if you see highly visible nutrient canals in between the teeth, you can see these radiolucent projections between the teeth. This is thought to indicate active disease or rapid destruction. And it's thought that these are larger blood vessels engorged. And here are some more nutrient canals. So, determining previous history of disease. So we know one has had a history of periodontitis by bone loss, right? And we think once they've lost it, it's very hard. You can't really grow it back. So once we see bone loss, we know that the patient has had a history of periodontitis. We don't know if it's ongoing, if they're currently active, but we know it's a history. Apical migration of the junctional epithelium, so a cal greater than 1, which we call loss of attachment. That's a history of perio. The other is if a patient demonstrates loss since their last visit. For example, if a patient has a cal of 3 and then the next visit they have a cal of 4, we know that they've had active disease in between the two visits because they've had 1 millimeter loss of attachment in between visits. So what would a patient look like if they were in remission or inactive, but they had a history of periodontitis? So that would be an inactive periodontitis. So it would look like this, or it could look like this. So we still see the blunted papillae, we see recession, which you may or may not see. You can see the root surfaces, which just makes it, at a quick glance, you know that they've had bone loss. And they have clinical attachment levels, but the signs that we're usually seeing of active disease, which would be redness, bleeding, swelling, we're not really seeing that much of it, right? The tissues generally look pretty pretty pink. No sites are bleeding. We have some very subtle rolling on the tissue, not perfectly knife-like. But the tissue qualities aren't bad for one who's had a history of perio. So this would be a great example of an inactive periodontitis case. We would guess that they're in a period of inactive perio, but they've had a history of perio.